Every second matters in airway emergencies. Master Rapid Sequence Intubation in under 2 minutes.
Keep your eyes on the screen and smoothly pass the endotracheal tube directly through the quartz. Securing an emergency airway leaves exactly 0 margin for error. It is a critical procedure demanding a methodical, checklist-driven approach to prevent catastrophic failure. To do it safely, we rely on a precise 8-step master protocol known as Rapid Sequence Intubation, or RSI. Before you even look at step 1, the patient needs to be completely set up. That means secure IV access, continuous ECG monitoring, and pulse oximetry must all be connected and running. If you start pushing paralytic medications without these baseline parameters locked in, you fly blind. An otherwise routine intervention quickly turns into an unmanageable crisis because you lose the ability to catch sudden desaturation or arrhythmias in time to correct them. Step 1 is preparation. You need to physically assemble your primary and backup tools right at the bedside before drawing up a single medication. This checklist includes a bag valve mask with a PEEP valve, active suction, an endotracheal tube with a stylet inserted, waveform capnography, and a backup surgical airway kit. Step 2 is preoxygenation. We need to flush nitrogen out of the patient's lungs and replace it with 100% oxygen, either for 3 full minutes or through 8 deep vital capacity breaths. If the patient is already hypoxic, you apply a non-rebreather mask combined with a nasal cannula cranked to 15 liters per minute to deliver maximum apneic oxygenation. While you execute this, do not apply routine cricoid pressure. The data shows it lacks any proven benefit for preventing aspiration, and it often physically distorts the airway, actively making your view worse. Properly executing this step fills the functional residual capacity of the lungs with oxygen. It creates a physiological safety buffer that buys you crucial minutes while the patient is paralyzed and apneic. Steps 3, 4, and 5 cover your pharmacology. If you are treating an infant under 1 year old, you begin with a pre-treatment of atropine to prevent reflex bradycardia. This chart compares the primary neuromuscular blockers. Succinylcholine provides an extremely rapid onset, paralyzing the patient in 45 to 60 seconds, and wears off quickly. However, it carries severe contraindications. Administering it to patients with burns older than 24 hours, recent crush injuries, or existing hyperkalemia will cause a lethal spike in serum potassium. When those conditions exist, rocuronium delivered at 1.2 milligrams per kilogram is the safer, modern alternative dose for standard RSI. You should avoid vecuronium entirely here. Its onset time is simply too slow for rapid sequence scenarios. Selecting the wrong paralytic can trigger physiological cascades that are harder to manage than the airway itself. You have to evaluate the patient's medical history to safely choose the drug. With the patient paralyzed, we move to step 6, the physical intubation. Before inserting any equipment, you must properly position the patient to align the oral, pharyngeal, and laryngeal axes. Place the patient's head in the sniffing position, extending the neck to create a direct line of sight. Using a video laryngoscope, insert the blade and sweep the tongue left. Identify the glottic opening, specifically looking for the inverted V of the vocal cords. Once you have that clear visual, keep your eyes on the screen and smoothly pass the endotracheal tube directly through the quartz. Taking the time to achieve correct geometric positioning and direct visualization is the only reliable way to guarantee the tube enters the trachea and avoids the esophagus. Step 7 is immediate confirmation. You cannot rely on instinct. You need objective data to prove the tube is definitively in the trachea. As we see on this monitor interface, continuous waveform capnography is the absolute gold standard. A steady, repeating carbon dioxide waveform confirms that ventilation is actively occurring. You pair this reading with secondary clinical signs, checking for bilateral chest rise, listening for bilateral breath sounds, observing moisture fogging the tube, and confirming no gurgling sounds over the stomach. To set the correct depth, you multiply the internal diameter of your endotracheal tube by 3. So for a size 7.0 tube, you secure it at the 21 centimeter mark at the teeth. Finally, we reach step 8. Use a syringe to inflate the cuff, sealing the airway. Then physically lock the tube in place with a commercial holder or secure tape. Until you have objectively confirmed placement and mechanically locked the tube down, that airway remains critically vulnerable to accidental dislodgement. With the primary goal achieved, the tube secured, and the patient successfully connected to mechanical ventilation, the emergency procedure concludes. But the protocol continues. You must immediately start sedation infusions, using agents like propofol or ketamine, to keep the patient compliant with the ventilator and comfortably sedated. Alongside sedation, you must initiate continuous analgesia. Fentanyl is the standard choice here to manage the significant procedural pain of having a tube resting in the trachea. The strict rule of post-intubation care is that patient vitals, oxygen saturation, and capnography must be monitored continuously without any interruption, and every single time the patient is moved, whether sliding to an ICU bed or traveling to a CT scanner, you must reassess tube placement. When a patient's airway fails, your margin of error drops to 0. Every passing second deprives the brain of oxygen, requiring you to establish a secure, continuous flow of air immediately, with absolutely no guesswork.